Welcome to the Grateful Life webcast. I'm your host, Ashley Eicher. Today, we're exploring innovations in dementia care with our guest, Dr. Beth Nolan. Dr. Nolan is the Chief Public Health Officer with TIPA Snow's positive approach to care. With a Ph.D. in applied gerontology and decades of experience in research and education, she now helps caregivers become care partners through evidence-based communication and relationship-building strategies. Beth, thank you so much for being with us today.
Oh, thanks for having me, Ashley. I'm glad to be here.
Of course, of course. Okay, let's start at the foundation. For someone who is just beginning to understand dementia, how do you define what it is and what it is not?
So what is dementia? Dementia is it's actually just a collection of symptoms. It's a syndrome. So a lot of times you'll hear in the media people flip-flop the phrase Alzheimer's and dementia.
Yes.
Alzheimer's is just one type of dementia you can have. So think of it this way. We're kind of diving in fast, but think about it this way. If you had an umbrella over the top of you and you put the word dementia, underneath it is Alzheimer's, one type of dementia. But there's up to 100, maybe 120 different forms, types, and causes of dementia. Anything from pediatric dementias, which are incredibly rare, to very late onset dementias. And there's the common ones we know about: Alzheimer's, vascular dementia, Lewy body dementia. They're all categorized and come about in different symptom expressions, so to speak.
Why do you think people are still confused by the term dementia versus Alzheimer's? Because that's something that's confused me.
Yeah, it comes up a lot. We still see media sort of superimposing those. We're not
Yeah.
getting the proper messaging. It would be like if the world started talking about prostate cancer and other forms of cancer.
Right.
It would
Right.
be kind of confusing. It would be like, lung cancer and cancer. People would look at you funny, but we're not at a place where people are comfortable talking about dementia. And I think as a result, media sometimes will actually think that the public can't understand if they just say the word dementia. There's still this
Right.
idea that we have to call it all Alzheimer's.
What are the different types of dementia and why is it important to understand the distinctions? I don't think I realized there were multiple different types.
Yeah, there's quite a few. So why would it be important? Let's go back to the cancer example. So if you're dealing with cancer, and let's say a friend came up to you and said, "Well, I have cancer." What would your first, beyond the "Oh my goodness, I'm so sorry," in sort of a
Right.
perspective way, right? What would your first question be? What would you say if someone said, "I have cancer"?
Type of cancer do you have?
Yeah, you'd want to know what type. Well,
Right.
okay, why? What does it matter? It's all the same.
But it's all different.
It's all different, right?
It's all
So
different.
the type of cancer then tells you what symptoms the person might be dealing with, which tells you what the prognosis is. Not only that, then there's that secondary question which follows up, which is, okay, so what stage is the cancer at? Because that matters too, doesn't it? I mean, if I had stage 1 breast cancer, they caught it early. It's going to be a tough road and there's going to be a lot of work to be done. But at that point, it's supporting a friend and figuring out what the next 6 months to a year looks like. But other types of cancer, it looks different based on the type and the stage. So now take this in dementia. If I have a certain type of dementia versus another, some are much more aggressive. So, for example, there's prion based ones that are like ones you can pick up in the environment, incredibly rare. But they are much more fast progressing than other forms of neurodegenerative disorders like
Hmm.
Alzheimer's, let's say.
Well, can you walk us through the four truths of dementia that will help us reframe the way we view this disease?
Yeah, happy to. So, the four truths, we think of it this way. The first truth is, well, actually, go ahead and hold up one finger. Now, hold up two. Is that to be a dementia, at least two parts of the brain are dying.
Mm.
Okay? So, the second one is that it is progressive, it is going to change.
Okay.
The second truth. The third truth is that it's chronic. This
Mm.
is not something I'm getting rid of. By definition, if you're falling under the umbrella of a dementia, it is a chronic progressive dementia. It is a
Right.
chronic progressive disease. So the last one, this is the one that I think is incredibly important for people to be told the truth about. is that when someone gets diagnosed with dementia, with any form of dementia, by definition, it's also, well, it's terminal.
Yeah.
Here's the crazy part though. So is life. And we've got to start thinking about dementias, the majority of them. Has anybody ever talked about how long people live with some form or type of cause of dementia? Have you heard how long people can live? Pretty long, isn't it? Sometimes people can live for 10, 15, 20, even 30 years. And if we're talking about terminal illnesses, that's a long time to just be dying. So
Right.
you brought this program up as as an innovation.
Right.
So when we think about innovations, it's really thinking about things in a different way. And so what I'm really hoping is that people begin to look at dementias, all forms of dementia, as not just the diseases that they are, but it's actually about how it is people live with the disease.
Mm.
Like I said, 30 years, 20 years is a long time to just be dying. These are actually lifestyle or life conditions. They're the
Right.
way we live our life.
Well, and I think so often, at least anytime anyone in my family or close to me was, diagnosed with dementia or Alzheimer's, it feels like with dementia specifically, it's like, oh, this could be like 2 years. Like it's a very short amount of time. So until you just said it, I don't know that I knew someone could live with it for 30 years.
No, it's devastating. And we have physicians, unfortunately, their job is to diagnose and to help treat us. And with most forms and causes of dementia, they're not curable right
Right.
now, as we have. So what I'm hoping one day is that physicians feel comfortable enough saying, my job here is to help you maintain your health while you have this other condition. In the meantime, rather than saying the very first thing I say to you after I give you a diagnosis is go get your life affairs in order, which sounds incredibly short and incredibly terminal,
Right.
right?
Well, and so fear inducing too.
So incredibly. I have had one friend with a neurologist that after he got a diagnosis, he turned to the doc and said, okay, doc, what do I do? And the doctor said, what do you want to do?
Hmm.
Always wanted to do. He said, well, I was kind of hoping that we would travel in retirement. And he said, then I think you should go travel.
Yeah.
Want to be with your grandkids? Go be with your grandkids. Do you want to be an advocate? Do you want to continue working? So it's how it is we figure out with this change that's come into our life, how we make those changes, how I learn about my condition, how the people around me that want to be with me and live with me
Right.
with my life, how I make these changes. So that's where the innovation comes in.
Well, and how can redefining dementia help reduce fear and stigma for families? Because, like we just said, it can be so fear inducing, not only for the person that was diagnosed, but for the people surrounding them that are caring for them as well.
Yeah. So if we think about dementia as a life condition,
Hmm.
5, 10, 15, 20, 30 years of life, we got to start thinking about how it is we're going to live, right? So if that's the case, then let's take one aspect of the way that life can change for us in a very negative way. We saw in the pandemic and all the studies that came out of the pandemic about social isolation. If in fact we isolate socially, then our entire health, our mental health, all of our entire well being begins to deteriorate. Now, isolation and getting social, we have to do it in ways that support us. For many people, we have to get the social that we like. It's not just social and everybody gets social. We got to figure out what social means, but we'll come back to that when we talk a little bit more about communication. But when we think about this idea of having dementia, I just don't know what to say. I don't even know how to talk to you anymore. Well, if you don't even remember who I am, how am I going to handle that?
Right.
There's so much stigma around the social that, in fact, many friends that I know that are living with dementia talk about the fact that people left them
Mm.
before the disease affected them in such a way that really would have had an impact. So it's a matter of figuring out how we start to educate the public. I am who I am. I am who I always was,
Yeah.
but I am changing. And I think that I think our relationship is worth it. But that also then means that you, if you're not living with dementia, you are who you are. You are who you've always been. But because your brain isn't dying, you can choose to be different. And then we can go from this or even this to actually getting to know how it is we can support each other. And some of the most amazing moments of support, education, enrichment have come with people who are living their lives. And then they've been welcoming enough to have me in their
Yeah.
life. It's pretty amazing.
Well, and I think we see that so often with diagnosis in the world that we are living in, where people just don't know what to say. And so instead, they just don't say anything. And so there almost needs to be an education too on how to approach someone who's just gone through a really difficult diagnosis and how to love them well. Do you
Yeah.
find that in your practice?
Yeah, that's a really great question. I mean, it's that place of figuring out where that person is. I mean,
Yeah,
at that early moment, a lot of people talk about having just unbelievable grief and bereavement. I'm mourning the loss of what I thought was going to be. I'm mourning loss of what once was. But I'm also trying to adapt to all these different changes that are happening to me and try
right.
to figure out what works for me. So in that moment, it does take a lot of patience and a willingness to ask the hard questions, but it also takes, well, it takes responsibility. I have a responsibility in a relationship if I choose to be in friendship to be responsive to that person. But if I'm really going to go and support someone who's in a tough moment, I got to get my house in order first. I really got to take some deep breaths and make sure that I'm in a good place for me so I
Hmm.
can focus on that other person. So, for example, if it's a friend, especially if it's a loved one, I too, not living with dementia, am going to be dealing with grief. And that doesn't diminish it just because it's not my situation. It is important, but it's also important for me to recognize that it isn't my dementia. I
Right.
do need to grieve, but yeah, I've got to step back and grieve apart. Because when I come and interact with you, I may not be meeting you at a moment of your grief.
Right.
Think of it this way. I had some family members who were dealing with cancer,
Hmm.
and it was a terminal diagnosis. And they said that over the course of the 2 years that they were living with cancer, that people would walk up to them and they may just be chatting and talking and or talking about, getting groceries or and then someone comes and says, "How are you?"
Mm,
And they had to turn and support that person in their
right.
expression of grief. And it
This
was so
happens all the time, Beth, all the time.
all the time. So we actually, when it comes to communication, a big piece of what we focus on in positive approach to care is how you approach someone, how you greet someone. And that really is a dynamic assessment. I approach you and say, "Hey," giving a visual, seeing what your response time is, and then I say, "Morning,"
Yeah.
and give it a pause. I can see exactly how long it took for you to respond to me right there in just 3 seconds, even before I've given my next thing, which is, "Beth,
Right.
hey." So you don't have to ask for it. I'm not already challenging you. "What's my name, mom? Mom, which one am I?" It's not that kind of an assessment. It's an
Yeah,
in the moment, friendly, supportive assessment where I can see where you're at.
absolutely.
You look pretty good. So I'm thinking we can have a normal conversation.
Yeah. Oh, that's so good, Beth. I'm so glad you shared that. Let's talk about a little bit more about innovation. So people often think of innovation as tech or medication. How is positive approach to care redefining innovation?
Well, I think that there's a lot of examples out there where social innovations are the key to living life. So what positive approach to care does is it takes and helps people become educated on what's changing in the brain, not just what is lost or is no longer, but what is retained. So it's the things I can work with. So the innovative part of it is it looks at how the brain works and
Mm,
how you are showing that ability and how I can support you. It's not ignoring what is no longer, it's not ignoring the loss of brain changes, but it's kind of like thinking that if you have lost a leg, that you'd be able to stand with assistance. Well, I need to make that missing leg work. That's kind of silly.
right.
I figure out how to augment the leg that you have because mobility is possible. It's just going to look different. Same with dementia.
So, can you talk about how relationship based care can shift outcomes for both the person living with dementia and their care partner, whether that's a partner or a caretaker?
Well, when it comes to care partnering
Mhm.
versus care giving, there is this inevitable unequalness about it. My job is to help you. Now, how does that feel if my job is always to help you, the lesser individual? At some point, you're going to get annoyed and I'm going to get exhausted. So, with person-centered care, it's wonderful. I can center on your needs. I think the intention behind it is really helping people recognize the focus. Is that I'm trying to figure out what it is you need, what's going to work for you. And that's a great first step. But if we're talking about 20 to 30 years of this, and my job is solely to completely support you, and we're going to assume that I, as the care partner, am getting nothing out of it, that's asking a lot. That's asking for burnout.
Yeah.
Let's think about it in context of an area or population of individuals who I think are a little bit farther ahead than we are in the world of dementia. So we think about parents and friends of people that have chosen to have friendships, chosen to be in the life of people with intellectual disabilities. If you ask anybody, it's not about being with someone because they're less than. That
Right.
would be so horribly insulting. But actually, it's a friendship. It's we get something out of it together. So a relationship-based approach is that I am also, as the care partner, getting my needs met because I do want to be helpful. But I also then need to pause every once in a while and recognize when the help I'm trying to offer is not working.
Right.
Does that
It's
work for both of us?
it's a lot. It's being self-aware. It's really being self-aware.
It is. And I think that's a really good point, Ashley. It does take a lot.
Yeah.
If I'm gonna choose to be in a relationship with somebody living with dementia, well, I've gotta choose to be different, and
Yeah.
it does take a lot of growth. I'm gonna make a lot of mistakes, and I think that's the place where coming back to what you talked about, this idea of communication, of friendship, and how do I talk to somebody? It's being willing to, when I screw up, say, "Ooh, I'm sorry." Even if I didn't do anything wrong, we can say, I'm sorry. That's not that didn't work out."
Right.
I'm not saying I'm sorry because I did something wrong. I can truly say I'm sorry because it didn't get the outcome we were both looking for.
Right. Right. What are some examples of how communication changes in dementia?
Ooh. So let's get down to the nitty-gritty.
Yeah.
So when we think about dementia, a lot of it comes to do with how we express language and how we receive language. Okay. So let's do a little bit of exploration of the brain for a minute. Okay. So well, let's try it with rhythmic learning because to be honest, we sort of like walk away from that when we're adults because we're apparently too cool to learn rhythmically. But I don't know any adult that I know of that doesn't do a little bit of a sing song when they do the ABC. So let's try rhythm. So we'll get this in. So go ahead and take your three fingers on your left hand.
Okay. Wait, left
Left foot,
hand.
left. Right, exactly right. Don't look at the camera.
Which hand are you talking about? Okay.
I'll do it this way. This is very rude, right?
Okay.
Left hand, left temple, three skill fingers. Okay.
Okay.
Now take your right hand and put it to your right temple, all five. Okay,
Okay.
so do it with me. Left, right, say it with me. Left.
Left, right,
One more time. Left,
left,
right.
right.
All right. Now here's what we're talking about. Here's how brains work. Language on the left, rhythm on the right. That little rhythm.
I like that rhythm you threw in there, Beth. That was
All right.
great.
That's what's happening in that left
Yeah.
lobe. It's language is on the left and rhythm is on the right. Now,
Right.
when it comes to almost all forms of dementia, not all forms, but nearly all forms of dementia, do this. We lose on the left, we retain on the right. So do that.
Okay. Lose on the left, retain on the right.
Got it. So, what is language? There's three skills that we are losing over here. So, the first one's vocabulary.
Mm-hmm.
It's the it's the things the things that I say like in a whole sentence, the individual little ones. It's that's like they're like nouns. It's the individual. What's the word I'm looking for? Words. It's
Right.
the individual vocabulary words that I'm losing. So I go from being able to talk all around it, losing that one little word, to the point where it sounds even more, I can't come up with any of the other words. So
Right.
go from, it's the thing that the kids wear. It's got like the zipper and that's like you put it up and it's not like a sweatshirt or like a sweater. It's got the, the drawstrings. It's the
Hoodie.
yeah.
Yeah.
Why couldn't I think of it?
Right.
I could come up with all those other nouns all around it. So then it may progress and word change and that language being lost to a place where I'm like, it's the thing with the, with the when you put it, and it's not that, it's where
Mm.
when you're you know I can't even come up with any of the other
Right.
nouns. Language is lost. Now there's two other things that happen in this side, this temporal lobe, this left temporal lobe. Specifically, it is comprehension and
Mm.
speech production. And now it's all in the same place, but you can see why they're three separate skills. For example, if someone has a stroke,
Right.
right? So think about that, right? Someone may lose the ability to have expressive language, but I still have comprehension, even if it's in that finite little area that was damaged. So my comprehension, unless we're talking about vascular dementia or strokes that happen that move into a place of a dementia, progressive chronic illness, I actually can, for the most part, get a clue about someone's ability, how much language they can comprehend
Yeah.
is being told by how many words they're producing. So if I can only give you about 3 words at any given time, how many words do you think you should probably give me back? Probably about 3.
Right.
It's a great way to do an assessment to figure out where someone's at. If they end up giving me more words, I might be able to try more words as well. So we actually do this. If you've ever been to a loud place, like a loud restaurant, I mean, or a really loud bar, let's say, and I can say, "Hey, Ashley, wanna go to the bathroom?"
Mm-hmm.
Or I may even go, if it's really loud, "Ashley,
Yeah.
bathroom?" And suddenly we can comprehend each other.
Right.
So it's keying into those ideas, adding some visuals, but I'm going too fast. Let's go to this right side,
Okay.
because here's where the strengths are. So there's a bunch of these over here. I won't go through them all, but this idea of, as language is being lost, I can use the strengths that are being retained. So
Right.
this right temporal lobe, this is like, the rhythm of communication. I can understand, and it's retained, the form of a question
Mm-hmm.
versus the form of a question. It's a statement, even when I say the wrong
Yep.
words. So the rhythm of speech, you can tell when I'm getting really upset at you, even if I don't really know that I am, because I'm just getting so desperate. You can tell the tone of my voice, the intensity, the frequency of my words
Totally shifts.
totally shifts.
Yeah.
I can hear you just fine. It's my comprehension that's changing.
Mm.
But there's amazing blessings over here as well. The blessings we have are things like rhythm, music, poetry, prayer, counting. If you go into any nursing home in the country or in the world, you'll notice that care partners, sometimes when I go from a sit to a stand, that will count. And you can even know exactly when we're going to stand up. If we're sitting down, it's 1, 2, and what are we going to do on 3?
Stand up
We're
or
going to
try
stand
to.
up.
Yeah.
So I can use these strengths. The part that seems to trick us, though, and the parts that seem to make us think that, well, that dementia changes who I am, changes who I've always been, is a funny little vocabulary replacement that's over here on this rhythmic learning side. And it's the place where we store all those swear words and those ugly phrases and those racial slurs, those things that the first time I said them, my mom went, and she gave me a big visual cue that I got to take that word. Ooh, that's a special word. I'm not going to stick it over the ball or milk. I'm going to put it over here and use it for a rainy day because that's
Right.
a powerful emotional word. So I may move from a place where I'm able to functionally tell you with a lot of descriptions, gosh, when you put me in the shower, I'm so cold, and it doesn't matter how hard you are heat it up. And I know you're sweating, but I'm just so uncomfortable. I to the point where I ache, and I can't see the water because it's clear, and it's hitting me like spikes on my shoulders. And I have some awareness. I'm just so embarrassed. And I just better if I just say no.
Mm,
I can't get all those words out and describe what's happening, but I can say no, no, thank you. No, just don't be an idiot.
mm,
Come up with those words.
mm. So, how do left or right temporal lobe changes affect someone's ability to express themselves? I know we've been talking about this a little bit right now. I mean, I just, to your example of, someone thinking that like the shower is too hot and it's just too much for them, but the only words they can get out are no, please stop, no. But for the person, the caregiver, I'm not quite sure what you're communicating and if I'm doing something wrong, if it's the water or what it is. So what do you do in those situations?
That
It's
is,
so hard to navigate.
it really is. And especially as a care partner, when I have an agenda, and I think that's the first place to start. You said it so beautifully earlier about this idea of self aware.
Hmm.
It's really looking into the mirror and recognizing, okay, what is my agenda? What is it the thing that I think I have to get done? Now, let's take showers, for example, a huge point of contention. So, if we think about a shower, what is the purpose of a shower? Like the ultimate purpose. Why do people shower? Think about that.
I mean, to get clean?
To get clean, right? So, does it matter at what point does health and safety, living my life safely, matter when it comes to taking a shower? Because it does. I want to acknowledge this. Is there a point in which my body can no longer really maintain itself comfortably? I'm starting to have
Mhm.
skin breakdown if I don't shower. How long do you think that is?
I have no idea.
We can do so we think about this maybe like camping or like when you didn't have power or water for a couple of days. When do we start to feel it? Some of us were very sensitive to this. It could be like just a day, or some of us it's a couple of days, or after like day 4, we're like, nope, this is my limit.
Right.
So that's a place just of discomfort. But if my sensory motor strip is changing, my ability to detect and feel and actually have that as a discomfort, I may be less aware. The thing that you're uncomfortable with is the fact that I smell or I look different than I used to.
Hmm.
This is the place where we can start to figure out, based on my agenda, recognizing it. Okay, shower isn't a matter of life and limb. If this shower doesn't happen in the next 2 hours, is someone going to die? Well, probably not. But
Right.
this is the place where I can take a breath. And then from there, it's learning how I get permission, learning these communication skills that we're going to talk about, because there's a couple of wonderful little tips and tricks that help us. But it's the place where I go, whoa, if somebody tells me no, they rescinded their permission. And
Mm.
I need to pause. I'm not saying I need to go away. I need to back up and say, wow, acknowledge, no, you're telling me no shower. I'm using your words and reflecting. Tell you what, and this is where we can start to use and practice some really key communication skills that Tipo Snow has been practicing for years now and has laid it all out beautifully.
Well, you use the phrase positive action starters. What exactly does that mean?
Yeah, so positive action starters are the ways in which I can actually jumpstart another part of your brain that may be changing in dementia. So the frontal temporal lobe is our executive control center. And that's the part of the brain that not only after I've taken in all the data around me, it actually can come up with a reasonable and logical conclusion. So the reasonable and logical conclusion to why I'm smelling something or I feel sticky or someone's telling me I should probably go take a shower, the reasonable logical conclusion is that I haven't taken one in a while.
Right.
Well, think about this in terms of my ability to assess time, another part of the brain, the campus, my ability to tell the passage of time. So I can actually have an easier time. Well, not an easier time. I remember that I have not had any cookies this morning. I can remember it's been a long time. And in fact, it's like a really long time since I've had cookies because I love cookies. But if I don't really like taking a shower, it feels like I just had one.
Right.
So we can see this if you ever have visited a loved one in a nursing home. And The minute that that beloved person leaves, immediately you can sometimes have a person turn to someone staff member and say, my son, he never visits me. You're thinking, he literally was just here.
Right.
So my hippocampus is changing. My ability to say, figure out how long it's been since something has happened is also dependent on how much I like it. The things that I like feel like they've never happened, and things that I don't like feel like I'm always doing them.
Right.
How do we then sort of jumpstart this? So there's actually 5 positive action starters. So the first one is a way to, well, it's part of the way we get connected. It's giving a compliment. So Ashley, you are so good at doing hair.
Thank you so much.
Fabulous.
Thank you. It's actually hair and makeup today. It's not me, but thank you.
Oh, hey, well, you've seen a lot then. You've seen a lot of good hairdressers.
That's true. I have. I have.
I could use your help.
Okay.
So can you just come with me? So right there, am I talking at all about a shower?
Nope.
So what was it that kind of like jump started you be willing to go with me?
Well, we built a connection. You built a connection on something that was not something I don't enjoy, taking a shower. I'm not saying me personally. I'm just saying, like in the spirit of this example. um, but you've connected on something like hair and makeup, and oh, you look so nice today, and providing a compliment that then I want to engage in the conversation on.
So the trick, well, not the trick, the connection
Yeah.
is starting with a connector. It's selling something honest. If I really didn't think you had fabulous hair, I couldn't really pull that one off. I had to pick something that I like about you that I know
Right.
is a truth. So if I ever get dementia, Ashley probably coming to me and saying, Beth, you are one of the best cooks I know. Yeah, I'm going to hear that one and be like, yeah, I don't think so. You're right. It's a sincere connection.
Right.
And it's something, but well, and I can tell if, now let's try it again. Let me compliment you on your hair.
Okay.
And let's say it's something that you literally, it's like you hate this feature of yourself. You think it is the worst thing in the world and you can't do hair to save your life. If I come up with a compliment and say, ooh, Ashley, you are so good at doing hair.
No, I'm not.
Oh, you're thinking you're not.
No, no, no.
So it's not going to be a point of connection.
Right.
I've got to pick something that you value. And I mean, most of our care partners, they really do know their person. But it may be that moment, that day, and I'm not feeling that great about my hair. So is that going to be the way that we get
Right.
connected and get going? Maybe not so much. So it's this idea. Our first one is getting your help. It's complimenting you in an area of skill or something about you. Ooh, you are one of the sharpest people I know.
It's building that connection.
It is, isn't it?
Yep.
And then it's I could use your help. It's the reason you're going to go with me. So the next one is try. And this is one I use a lot of times in combination with I could use your help. So if you think about this, when you talk about living with dementia, living with neurodegeneration for years and years, there's been a lot of times where I'm not stupid. I have dementia. I know that I used to be able to do something, but I can't anymore for many folks. So sometimes giving a compliment and asking for someone to use their help, they are actually a moment where like, well, I mean, if you want, I don't know how much I can help. There's a self-doubt that comes out. This is my next one. Let's just try. Tell you what, this idea of let's just try, we actually use it pretty frequently in a whole bunch of other situations. And this is the time where we start taking these ideas and recognizing they're not rocket science, but they are neuroscience. And I've used this again and again with let's make it much more simple example, not a full-fledged adult, but a child. So how many of you guys have ever made the mistake of right before you get in the car, you tell the 3.5, 4-year-old, tell you what, kiddo, I want you to go to use the potty. And then what is the child automatically that like prompts almost universally for the child to say back to you?
Typically says I don't have to go to the potty.
I don't have to go to the potty. Well, here's the crazy thing. If we knew about neurology and physiology, we would know that in truth, in that moment, what happened was I said to the child, use the potty. And a body who's trying to learn how to potty train immediately, it actually triggers the round muscle to go, the sphincter muscle to squeeze up. And if you squeeze that sphincter muscle hard enough, You actually diminish the sensation of having to feel like you have to go to the bathroom. So when that toddler or little kid comes back to you and says, I don't have to go, oh my God, they're telling me the truth in that moment.
Right.
And who caused it?
I did.
Oh, we
Or
did.
you did. Yes.
Why did I ask? Why did I ask a question I wanted answered? Same idea.
Right.
So now, when you know that child 20 minutes into the car ride, as the amygdala decreases, as the sphincter relaxes, what's the first thing they're going to say? Hey, mom,
Got to go to the bathroom.
gotta go to the bathroom. And we immediately say, well, why didn't you go today? Breathe.
Yeah.
Same idea. So when I ask the child and make the mistake, hey, kiddo, I need you to go to the bathroom. I don't have to. What's the next phrase that we generally will use?
We'll just try.
Let's just try.
Let's just try.
And the minute you plunk that little tookus on the toilet, what happens?
Sometimes they're going to go to the bathroom.
Leave it a little bit.
Something.
So I can, in a moment where someone gives me, and I've done it. I have asked a yes, no question to a question I didn't want to know for. Or there's self-doubt. I can say, tell you what, reflecting their level of intensity, let's just try. Your face is pretty relaxed. You got a smile. You just told me no, thank you. I don't have to. Tell you what. So now put this as an adult. Same concept, that let's try positive action starter. Put it in the context of an adult. Why would one adult to another suggest a bathroom? You seem to handle this just fine. I mean, you're an adult. You got to think of reasons why it's logical or why it would be logical. So since we're here, hey, Ashley, come on. Since we're here, we can be going somewhere, doing something. And it makes logical sense. Since we're here, now that we've got the big visual cue of the toilet right from the hallway.
Right.
Tell you what, you go first, I'll wait.
Yeah. Makes so much sense.
We got to quit treating people like they're less than. We got to quit treating people like they're children. We can get clues from how we've been successful with kids. Those are those verbal interactions. But at the end of the day, I do not have a right to make another adult do something they don't want to do. And so far in dementia, medicine and nursing and social work and psychology, we seem to have got this idea that I know better than you at all times.
Right.
Baloney, isn't it? You're an adult.
It's so frustrating.
Really is.
It can be so frustrating. That is such a great point. Okay, let's change gears just a little bit. How do changes in perception or vision affect how someone interacts with their environment?
So this idea that vision changes, you're kind of getting the idea here. You're catching on fast. This whole idea that
I'm a quick study, Beth. I'm a quick study.
well, you are one of the smartest people I know.
Compliment me more, Beth. Come on.
Right? I'll do anything. We'll be care partners in the truck. You think about it, it's not just about language, is it, that changes. So it's also about all my other senses are changes. My sensory motor strip is also, this is up here at the top of my head. It actually is functionally a full map of my entire body. So how vision changes, the next one. So go ahead and actually do this and think about it as like eyeing the canvas. This is our first and primary way we take in data. And it's one of the most important. Followed by, we started down this idea of language changes, this verbal. The second way we take in language is what we hear, our auditory. These have to match. But I got to know how this is changing for us to figure out how it is you're doing things that don't seem logical to my experience of the world, not living with dementia. Okay. So we're going to try something.
Okay.
I'm going to have us go ahead and stand up.
Okay.
Right.
Okay.
When I tell you, I'm going to have you put your arms straight out to your sides.
Okay.
Wiggle your fingers until you can see them just on the edge of your peripheral vision. Okay, so just like this, I'll turn sideways to the camera.
Okay.
So I've got it back here and I'm looking straight forward. And I'm going to wiggle my fingers until I can see them just on the edge of my peripheral vision.
Okay.
From just beyond about here.
Yep.
Okay? So now I'm 53. You don't have to say your age. But it kind of gives you an idea. I had a decent night's sleep. But if I was 25, and those of you who are listening to this podcast, do it if you will. Go ahead and put your arms out and actually wiggle your fingers. See where your peripheral vision begins. Because as I age, I can only take in so much data. Now, no dementia, 75. Go ahead and bring it here to about a 45-degree angle.
40, you want to go here?
Yeah, there you go. Nice. Okay. Perfect. What this actually looks like, it's not just from side to side that begins to change, but it's all the way around.
So then
Think about when you're really distracted, you're really in a hurry, and you've had that throw rug in your kitchen for 20 years. But as you've aged, you found that you trip over it more and more.
Well, because if your vision is just right here in front of you, that makes so much sense.
Yeah, I want a taller dog. Many of you have like slid the poor cat across the kitchen floor, right? Exactly. So as I age, I can no longer take in the data around me as fast, process it. And the two data we're talking about here are two individual images from my eyes. And I flip around and line them up. Kind of amazing what it does. I'm actually seeing things with the back of my brain, the occipital lobe, and it's pretty high up. So this part of the brain processes vision. And it actually allows me to take in those two images, flip around and line them up so
Hmm.
I can actually see the world in 3D. So the crazy thing about vision, it actually goes from no dementia. It's about here. It's like looking through a portal of a ship.
Oh,
So
wow.
now any one of us, now let's take it to dementia, or any one of us under extreme stress or hyper focus in that moment. Go ahead and make two C's and put them around your eyes. And if you go ahead and take it down, you can see just how much of the world
Mm-hmm.
you've actually can no longer pay attention to.
Oh, yeah.
And I use that word very carefully because it's not that you can't see it. It's not that your eyeballs are changing. They may be. There's a lot of age associated vision changes that happen to my eyeballs, the mechanisms themselves.
Right.
But in this case, we're talking about processing. So it's my ability to take in all of this data. Now, think about it. When we're talking about peripheral vision versus center or task vision, which you get more detail, more data from?
Peripheral.
I get a lot of important data out here, don't I?
Yes.
But out here, I see just the motions and colors, maybe some flashing lights. It actually allows me to, if I saw something flash right out here off camera, what would I do?
Turn, stop, something. You do something.
It's important. It's actually our protective reflex, our ability to recognize there's something important I need more data from. I actually put
Yes.
my task vision and we'll look at it to get more information.
Okay, so if we put all of these approaches together, how does using the right approach reduce frustration and conflict in families or in relationships and in daily care routines?
Yeah. So it's how we set things up.
Yeah.
So if my vision is changing, for example, just in vision, if I'm here, do I want to, well, where do I want to come from?
Mm.
If I'm approaching someone and I don't want them to be startled by me, where might I choose to come from? The side where I'm not going to see you or the
Right.
front? So it's the little things that begin to change the way our interactions start off. I mean, if you've ever startled someone, you really have to take a moment and let them calm down for a bit. And how much am I able to get my agenda met if I've already surprised you and made you uncomfortable?
Right. These are just lessons for life, too, Beth.
They really are.
They
It's
really are. I mean, everything from self-awareness and how you approach people, like obviously we're specifically talking about dementia, but it's being aware of those things in your day-to-day life.
it is. And that's actually the real innovative part of this. Positive approach to care is not about treating people with dementia differently. It's about recognizing the person as they're functioning in front of you at this
Yes.
moment and setting both of us up for success.
How can families navigate difficult decisions about care settings while honoring the dignity of everyone involved?
So that's a tough one. How is it that I basically help the person maintain an independent life as much as possible
Right.
safely? So, when we're talking about this idea of safe living, it's a matter of figuring out where can someone live and get access to the things they need. So, it's having these decisions as early on as possible. And this is why I so appreciate you putting out this information because if we can destigmatize dementia,
Yes.
we can start to talk about what's important. So, let's start here. There's kind of two types of people, and it's a bit on a spectrum, but there are those people who are extreme risk takers. I'll just try anything. I'll give it a whirl. What the heck? I'm in the moment. There's also people who are safety seekers, and it has
Yeah.
nothing to do with courage or bravery or anything. It's just where your comfort is, who you are as a person. So I am the person that literally would love to throw out a backpack and show up in a city and see what happens. I mean, as I get older, I'm not stupid. I have a little bit more self awareness of what I can and cannot do. But at the same time, I'm really open to giving anything a whirl. Generally speaking, a lot of us have married someone who's very different. So I have a very safety seeking husband. We actually call him safety dad. He'll put on literally steel toed boots to mow the lawn. And this is amazing. I mean, he's not going to get hurt and he's not getting injured in stupid ways, but I tend to be a little bit more free flowing. So
Yeah.
now enter dementia into the picture of our relationship. I actually, if I'm living with dementia, knowing my husband's personality, what is he likely to want to do to me?
Create more safety for you, I would think.
Keep me safe as
Yes.
anything. There's a reason why he loves me, and likewise. So, this is a place where I have to figure out how it is that if Beth is living with dementia, she gets to take the risks that she always wanted to because she's an adult and, she's, well, yes, things are changing. Judgment, reasoning, those are changing. But it doesn't mean that you're allowed to end my life. You're
Right.
allowed to make all the decisions. We got to figure this out. But likewise, my job may be to recognize in my risk taking that I really need to look at things from my husband's point of view and figure out how I help him feel safe so that
Right.
he can do the things that are risky.
Right. I really like what you said about destigmatizing dementia because it is so hard choosing what is right. So often it's so hard to know for a caregiver or a partner. So, what advice do you have for caregivers who feel overwhelmed or unsure about doing the right thing?
So let me ask you this. In any relationship, how many years did you go where you only did the right thing?
About 5 seconds.
Yeah, I think that's wonderfully self aware. The
Yeah.
reality is, we're talking about human interactions and we're going to make
Yeah.
mistakes. I think this place when it comes to dementia is suddenly I feel like it's my responsibility to do everything right for you. And this is where we get to a place of this, recognizing that I got to figure out what's going to work best for the both of us. Figuring out and maybe taking a moment to breathe, to consult other friends, to consult professionals to figure out what is the most likely best pathway forward. So, the idea that I'm going to make a mistake, I got to learn the art of letting go.
Yeah.
And believe it or not, that's one of the hardest things I've got to do. That's going to take some work. And I actually really encourage anyone living with dementia, whether it's you as a person living with dementia or you're living with dementia in your life around you, that if this isn't a traumatic experience, I'm not sure what is. It is a time to engage in professional help and get the support you're recognizing. Okay, where is it accurate self awareness?
Right.
About frontal lobe. Am I accurately assessing the situation or do I really need help?
Hmm.
That's the piece I think can really help.
You mentioned tools like 1 minute animal fluency that can help detect changes. Can you share with us what that is and why it's so helpful?
Yeah, the 1 minute animal fluency is a great tool that's incredibly accurate to give us free, takes a minute of time to give us an accurate baseline of where I am at any given moment. And we can actually do this together. Now, we won't take the full minute to do it, but all it takes is a stopwatch or maybe a little clock here. And we're going to do this together, no matter where our brains are, because it gives us our baseline, no matter where this baseline is at this moment. So in 1 minute, Ashley, I could use your help. Notice the positive action starter. Listen, in my family, there's a lot of folks that, well, we get dementia in my family quite often. So I could use your help. I'm going to start my timer for 1 minute. And if you would, here, take this paper and this pencil. See if you can mark down the number of animals that I can name in 1 minute. Okay, ready? Go. And we're just going to do this for a minute and mark it down. And then we'll switch. You'll try it, and then we'll have our baseline. Now, here's the cool part. There's no right or wrong here. I have, Teepa Snow, the woman who created this program, Positive Approach to Care, she actually got an undergraduate in zoology. That woman can name like 30 something animals in a minute. I'm somewhere between 14 and 18 on a good day. But here's the cool part, it's my baseline. So if you see me changing and I'm going to 12, 10, 9, this is the time where I go, something's up. We need to look in to see what these changes are caused by. It could be anything from sleep to medication to poor diet to stress, or it could be I've got some neurodegenerative disease. It's the place where I can get an idea of how I am now because change is the key feature. Now,
Right.
Tifa, if she hits, well, 28, 27, 26 animals, it's a lot more than my baseline. They're not comparable, but it's a change for her. That's our 1 minute animal fluency.
Absolutely. Can you share a story or example that shows what's possible even after a dementia diagnosis?
I would love to. You can see my smile already.
Yes, you lit up.
Well, so I think that's the piece that's possible with positive approach to care. This ability to recognize I can learn things in dementia, I can learn things as a care partner, and together we can actually truly recognize that life is possible. So I recently had a chance to join a group called Walking the Talk for Dementia. And it's this amazing group of individuals that showed up from 30 different countries all over the world, organized by an Atlantic fellow. And the way that he set it up is you walk the Camino for 4 days with a mixed group of individuals from all over the globe, professionals, family care partners, people living with dementia. And at the end of it, this journey that we've taken together, no matter what our functional, physical, and cognitive abilities are, we've overcome something together.
Mm,
And after that, we come together and talk because we've spent so much time together as human beings. All the titles and the education, they walk away, and you're learning and growing and being with people. And then we come together in Congress, we come together at a conference and talk about dementia specifically. It's an amazing journey. And I think it shows how, well, what's possible in dementia. I
right.
don't know if anybody's ever taken the Camino to Santiago, but there's quite a few stairs, and you may have seen there's a variety of physical abilities, and we did it together, and that's the point. It's a true example of care partnering, respect for all individuals, and individuals can achieve so much together.
That is so beautiful. I love those photos. That look like the most amazing experience.
Truly was.
What would you say to someone who has just received a diagnosis or is caring for someone that is newly diagnosed?
So, newly diagnosed, this is the place where I say, okay, we got to figure out what we've got.
Yeah.
And part of it, that actually is taking a lot of energy. It takes a lot of energy to recognize. So I could hunker down and it's just me and my partner living with dementia, but this is going to pinch really fast. So I'm going to ask everyone to begin to open up, to recognize that there is so much support out there. And even if it is going onto YouTube, your first step and looking up Tipa Snow, it's a place where I can begin to be educated and to see what's possible in dementia. So much of the education out there has to do with what's being lost.
Mm,
So think about it in terms of like a donut. Okay. So picture a traditional donut, the round one with that hole in the middle, right? What if I was to tell you, you've never seen a donut before, never tasted one, never had the chance to eat a beautiful, amazing donut, and all I told you about was the hole?
mm,
Wouldn't sound that great, would it?
right.
But in truth, there's a whole bunch of stuff that's out there that's around it.
Yes.
I mean, yes, dementia by definition, there's things that are changing, there's things that are no longer there, but it doesn't negate the things that are there. It will take change and it takes a lot of awareness. But the cool thing about it is that if I am living with dementia, I am who I am. I am who I always was. But I also am different and I can choose to be different too.
Yeah.
But that's what the care partner as well. Together we can actually come together, but it's going to take some time. Give yourself that chance to grieve. And at some point, we got to figure out how it is we come together and build a community. I can't do this alone.
Right. Well, some caregivers may have heard of your GEMS model. Can you explain what that framework helps, how that helps people to understand progression in a more compassionate and practical way? I feel like the entire theme of today has been compassion, compassion, compassion. So can you talk just a little bit about that?
Yes, and it's compassion not just for somebody living with a brain change, but also compassion for myself. That's kind of the
Yes.
theme that you keep bringing up so beautifully. So our gem state model is functionally a progression model in brain change. But so what it's based on is, well, they're phrases that all of us can understand. So for example, think about a diamond. We can think of the properties of a diamond. wonderfully expensive. They're shiny. They're one of the most valuable gems out there. They're also one of the hardest. They can cut anything on the planet. They're Now think about these same descriptors that we know of diamonds, that we all as a common language would know that makes up a diamond. Now take that to a person. I know the value. I know exactly how much things cost. I am very clear and I know who's the boss here. I am really amazingly, well, I'm very valuable. I have amazing facets and, well, I also am skilled enough to cut you if you're not a little bit more respectful. I am incredibly hard. I like what I like when I like it. I like my routines, but I do like something a little bit different. The same way that my diamond can catch the light and pick up the colors around me. So our gem state model is based on gems: sapphire, diamond, emerald, ruby, pearl, amber. It's an amazing array of gems that tells us that no matter where I am in my progression of dementia, or any one of us in a moment of brain change, we have value. We
Mm.
are worth it. But it also is respecting what that gem is like.
What are some of the really practical ways someone can interpret this model?
So, aside from the beautiful analogy that gems are, it's actually a very practical model. The gem state model is based on the Allen cognitive functional levels. It's an occupational therapy approach that looks not just at what is lost, but what is retained in terms
Mm.
of abilities. So, at any given stage in dementia, I have a certain number of abilities or certain things that I can do. And by knowing that gem, I know then better how to interact with you in any given moment. So, for example, take amber, the precious. Well, it's not even a stone, is it? It's one of the few gemstones that isn't a stone. It's hardened tree resin or sap, isn't it? Pressure, time, and heat over millions of years makes something valuable. But we know that because an amber started as sap, it can actually catch things in a moment of time. We've been able to see pieces of wings of an insect or a leaf being caught in what is now, well, a stone, a precious gem. So for an amber, I am caught in a moment of time. I am all about the sensation. Ambers feel very different than, let's say, touching a ruby or an emerald. But an amber is all about sensation. So in my gem state, I can functionally recognize that a person living in an amber state is all about sensation that I get. And what I'm doing is meeting my needs of getting that sensation in.
Mm.
So with the gem states, I can actually, at a glance, recognize, let's say, someone outside someone's room and see a gemstone. I can get an idea of how they might respond, what their processing speed is, where their visual field is. We talked about this progression of vision. It actually goes from sapphire to diamond to to emerald to amber, where I have some object confusion, to ruby, and then pearl, where I go from full vision down to only being able to see things in monocular vision. And I can recognize maybe where it is if I want to present something, where and how fast I present something,
Right.
if you're interested.
This is so interesting. Where can we read more about the GEMS model and these particular GEM states?
So you can literally go to teepasnow.com. You can look her up on YouTube. In fact, if you just Google Teepa Snow, and it's Teepa,
Hmm.
snow, it's stuff that falls from the sky. But in there could be the beginning. Watching videos is not necessarily the place that we want to end our education. If we're talking about helping and supporting somebody live with some of the most complicated neurodegenerative diseases on the planet, this is the place where I might need to move from just watching to actually trying. So once you get engaged with us, we have interactive classes, we've got group classes, we've got a way in which we can figure out how to try something different. So just the same way that I wouldn't expect you to, after I've watched hours and hours, maybe 100 hours of video of flying an airline, want to get in the cockpit with me while I fly this plane? Probably not.
I mean, Beth, I trust you, but I don't think so. I trust you at this point, but that might be taking it a step too far.
Too far. Yeah, exactly. So we've got to move from a place where we're just watching to we're actually trying things,
Yeah.
trying out these positive action starters.
So it can be so easy to get wrapped up in the difficulty of this disease or the fear of it. How can we help people to see the full humanity of someone who is living with dementia?
I think this comes back to this idea of connections first. If I'm going to help somebody move their own gem state, move their own ability to look up and look out and see what's possible, I really need to meet them where they're at. And that actually is being willing to listen first. So you may have heard a few times this reflective language that we use. When I'm verifying and showing you that I think I understand the question you've thrown out, I'll give it back. Reflection. I can actually approach someone, a friend, and say, hey, morning, do a greet with a nice visual, see where they're at. And then I can say, so how's it going? Adding in that visual, remember that primary way we take in data. So, Ashley, how is it going lately? Here, or not so much.
Yeah.
So, someone may be able to show me rather than tell me sometimes how's it going. Because I don't want to come in and say, life is possible living with dementia. Because notice what it is I look like. I look like I'm about to attack you, don't I?
Yes.
Am I likely to be able to push onto you this idea that life is possible with dementia if I haven't even met your needs first? It's
Right.
just not something we're doing respectfully.
So I love this. So meet them right where they are. Reflective language, all of it works together to destigmatize dementia. So good. Okay, let's transition and see. We've got some questions from our audience. So I want to make sure we get to those. How do you deal with insomnia in people with dementia?
Oh, wow. This is a tough one because we deal with insomnia and when you're not living with dementia quite a bit
Right.
too. So, insomnia, we got to take it from its aspect of thinking about how it may be slightly different in different forms of dementia. So, for many of us who are living with dementia, regardless of the type of dementia does affect my ability to determine the difference between night and day. My ability to interact with the world initially becomes much more challenging. So, just trying to figure out, and if you will, let's take this moment and we'll get back to insomnia. We're getting there. Go ahead and actually put on goggles. And as you're watching the screen, maybe go ahead now and with your goggles on, try to find your phone and notice how much more effort that took. Now, can you imagine if every single thing you saw, you heard, you tried to say, you felt or did took just a little bit more effort? How much more exhausted you'd be? So, how it is that my body and my brain are affected by dementia can very much affect my wake sleep cycles the same way that affects all my other senses. So, it even becomes even more important when we're talking about something like Lewy body. When we're talking about Lewy body, many of the movement disorders, my ability to actually have night and day sleep cycles that are going to work for all the others in the rest of the world sometimes be completely obliterated. So, depending on the type of dementia, recognizing that I may have to let it go. I may have to see when you can get the sleep you need whenever you can get it. This is where I got to go, whoa. I got to pull on my frontal lobe and think, wow, am I at a place where I'm able to actually support my own health if you're up in the middle of the night and my worry is keeping you safe?
Yeah.
When it comes to insomnia, it is all of the stuff we've learned about before. It's doing those sleep hygiene practices. It's cooling down rooms. It's making sure that we have, sleeping with layers, that the sound isn't quite as up and down as it normally would be. But it also has to do with how it is I'm getting exercise throughout the day. I've got to treat myself so much better as I age and then also in dementia so my body can get the rest it needs.
Yeah.
So it comes with all lifestyle changes that we're aware of, but recognizing when it comes to insomnia and dementia, sometimes I got to pause, see if I need to get in professional help, but also recognizing that this wake sleep cycle I'm looking to have, I can move from doing 12 to 14 hours awake to a good 8.5 hours of sleep to this place where I'm actually more like a deer 2 hours awake, 2 hours of sleep, 2 hours awake. And that's as good as my body can do as my circadian rhythms begin to change.
Yeah. So let's talk just a little about guilt. This is a really This is a really tough question and really powerful. How do you deal with the idea that you are constantly lying to your loved one?
How do you deal with the possibility you're lying? So I'm going to ask you this and ask all of you out there. What are you lying about?
Mm.
What are you telling somebody that is an absolute untruth? So, for example, many people will talk about this idea that my mother is always looking for her husband. And I tell him he has gone out because I don't want to tell her that he died 20 years ago and she doesn't remember because every time I tell her, it just crushes her. And I'd say you're absolutely right. This idea that I've got to look at the outcome of what it is I'm saying. But if the guilt becomes so powerful that I find I'm making up stories and then I get trapped in this, oh my gosh, suddenly my mother has a moment of lucidity and she calls me on something. She's like, what are you talking about? Think of a car. What do you mean? I would have known if I put the car in the shop. You can't tell me my car's in the shop. This is ridiculous. You've stolen it from me. We can get caught in lies. So I'm going to actually ask us that to take a pause and figure out this idea that, well, let's ask ourselves why we're lying. I don't lie to my friends living with dementia. That's a pact I've made. But it's taken a lot of practice because sometimes telling somebody the whole truth is more cruel. Now let's take this outside of dementia for a moment because this is something we can all understand. A friend walks up to you and they're beaming and they're in the tightest dress you have ever seen them wear. And they say, don't I look fabulous? And all you're thinking is, oh my gosh, how did she get those buttons closed? Wow. Now, when someone says to you, don't I look fabulous? Are you going to say, no? Did you look in the mirror? You've gained 20 pounds. You should not be in that dress. Whoa. We do this all the time. We have phrases that we can come up with that can help us get over our surprise and buy us a minute to give something in support. Because if somebody thinks they look fabulous, I think they should look as fabulous as they want to look.
Right.
So I actually have a phrase that I use for me. It's a place where I can not only give a statement that is kind of neutral, can go either way, positive or negative, no matter how they want to take it. I can say, wow. And the cool thing about the word wow in the English language is it also allows me to breathe out.
Hmm.
Because if my friend walks up to me and says something that's incredibly shocking, my whole body actually reflexively goes,
Right.
I've got to breathe out in order to think. I actually have to go, wow, is it new? Or wow, that color, that's a beautiful color. I can think of something that is honest. That's the place we begin to start. If
Yes.
someone says to me, I'm looking for my husband, and I know their husbands died. In fact, I went to their funeral, and they were the ones that was with me when the I can say, "Wow, so you're looking for your husband." I got to get curious. I got to figure out where that person is in time and place because the reality is if somebody is looking for their husband, I got to figure out why they're looking for their husband.
Right. That makes so much sense. Makes so much sense. How do we know if aging in place is safe and advisable with dementia? And where is the line between independence and safety?
Whew. Well, this is that self awareness we're talking about, recognizing what is health and safety. And I will say that most people, when they get to that place of looking at health and safety, they're kind of end up in two camps many times. They're really at a place where it's not about safety yet. It's really someone that's safety seeking. They want to make sure that they've accounted for all the risks in the life and that's really a place where I got to take a pause and take a breath and figure out what I can do to augment that situation, what I can do to think about how I can alter the environment. But then there's the other side of it. And this happens a lot of times with folks. If you're listening to this and you're talking about someone in senior living, many times it comes down to a place where something really awful has happened.
Hmm.
And it's we've gotten to a place where things were no longer safe for quite some time. We realize mom's been living off of peanut butter and crackers for months, and her nutritional deficits are just horrible. Or there's been a terrible fall, and there's been multiple falls. Or, well, this is the place where I start to look around. Is Can I start to alter the environment in such a way that's still supported for them? Can I see about having a reasonable and logical reason for that person that someone else can be there? Can I see about a way of maybe bringing in meals so it decreases the likelihood that I'll cook or even cutting off the gas to the stove so I can keep things safe. And so whenever you say, I can't figure out why the gas won't work on here, I'm like, huh, that is so interesting. It will not work. So when you're looking to cook the spaghetti you got out or something else, I can get curious to figure out what the unmet need is. Oh, I'll tell you what, well, let me see. Let's check out over here because I know that I might actually find spaghetti in the fridge because I've been getting the meals delivered. So this is the place where I start to break it down and figure it out environmentally. Is it the environment that I may be able to alter? Is it some sort of social supports that are being needed to be met? Is it how someone is actually going beyond their environment? And I figure out how it is I help them get out so they even want to come back in.
Right.
It's a multiple factor. This is the place where we start to begin to, well, this is where I got to check in. I really do need to check my own self awareness. And I do need help to gauge, is my understanding of what is just a little uncomfortable versus is it actually just a feeling definitely risky? Or is it really a danger to life and limb? We need to move her tomorrow.
Right.
This is where I need some help. A little bit of perspective can help. Your point of view and mine coming together to figure out the best plan forward.
I love that. Okay, this is a tough question, but one that we hear a lot. What are some signs that the end of life is approaching in a person with dementia?
So, the signs when life is approaching the end of life dementia. When we think about end of life, we hear people much earlier on in the disease process. We'll hear people that say, well, my mom is really far in the disease. There's not long now. She no longer recognizes who I am. And then when we inquire more, we find out the person is still ambulating around their world. They're still eating foods. So when we think about true end of life, I can live without language functionally in a way that we think about it, language, speech production, for quite some time. So when it comes to end of life, we're talking about systems shutting down. We're talking about the brain and the body saying, no more. I'm no longer able to fight off infections. My brain can no longer recognize in my body that some invasive organism has come and I can muster the white blood cells. I can no longer recognize that. And I keep getting UTIs again and again, urinary tract infections again and again, no matter how many antibiotics we try. Or when I am beginning more and more without the proper support and assistance from an occupational therapist and a speech pathologist to help you eat, I am no longer able to take in nourishment. In fact, I'm trying, but I'm no longer able to swallow as well. And I'm also no longer digesting things as well. So it's when we've got a combination, not just of skillful supports, but then even with skillful supports, my brain and my body aren't working together anymore. We'll
Right.
see a lot of weight loss. We'll see aspiration. We'll see, well, we'll see a lot more of time where I'm actually sleeping versus shutting down. I'm truly spending less time out and more time in.
Beth, this has been incredible. Thank you so much for being here with us today. You had so many incredible examples and just so much powerful information to share with our audience. So thank you just for being here with us today.
Oh, thanks for having me. It was fun.
If you'd like to learn more about Dr. Nolan or Positive Approach to Care, visit the links you see on screen. And as always, you can find this episode and more at brookdale.com/webcast or on our YouTube channel. We hope you'll share it with anyone who might find it helpful. Thanks for joining us, and we'll see you next time.